Good evening, everyone. I want to thank you for joining us. Dr. Liz is with the Foster City location of Holtorf Medical Group. She's going to present some great information on why we shouldn't be afraid of hormones and how they can benefit women as at any age, but as we age as well. And we will be taking questions towards the end of the call. Please feel free to text those to me. I will be gathering them, and then I will be able to ask Dr. Liz those questions. If we get overwhelmed and it doesn't get answered, we will be sending those questions out in the email probably tomorrow, the next day, with a copy of the webinar that will be posted on our website. So please feel free to send those questions to me throughout the call. And without further ado, I'd like to introduce you to Dr. Liz Lyster of Foster City Holtorf Medical Group.
Thank you, Jenny. Can you see my screen?
Yes, ma'am.
Great. All right, fantastic. Well, it is, I have 6 o'clock right on the button. Is that what you have?
I have just 2 minutes after, so we're perfect.
All right, great. Well, this is to acknowledge everybody who is already on the call right on time. Let's see. All righty. And we are going to cover a lot of really fun and interesting information this evening. And so I welcome everybody to this call, and it'll be very great to have it posted on the website so that you can share it with friends, people who couldn't be on the call live, and because we really want to get this information out there. So I'm excited about that. So for those of you that don't know me, I am Dr. Liz Lyster. My background is actually in OBGYN, and my practice narrowed itself all the way down to menopause, hormone balancing, and helping women with weight management. And over the course of the last few years, I pursued advanced training in hormone balancing, bioidentical hormone therapy for men and women, and that's what I am lucky enough to have the opportunity to do for Holtorf Medical Group. So I'm up here at the Foster City location up near San Francisco, and I am very excited to present this information to everyone this evening. So we'll have some good stories throughout, and lots and lots of very, very good information to share with you. Jenny, I'm seeing in the text chat showing that.
Yeah, I'll take care of her.
All
I'll
right,
send her an
beautiful.
email.
I'm going to minimize
right
this
now.
box, and then I've changed it so it won't pop up when there's new people that are doing the chatting with you. So I think that'll work well. All righty. So so we probably have mostly women on this call, although there may, of course, be some men on the call as well. So my comments are directed mostly to the women in the audience, since the title is Why Women Shouldn't Be Afraid of Hormone Therapy. A lot of what we will talk about, though, will be usable information by women and men, since we all know people who have had hormonal imbalance, who have not felt well, not felt like themselves, and had doctors tell them that hormones are scary or dangerous, and we're going to dispel those myths this evening. So this is a little cartoon from a Women in Medicine magazine showing all the juggling that we do nowadays. We're all very extremely busy, and things can pretty easily get out of balance. So I, again, appreciate the time that people have taken to be on the call this evening. This is a little illustration of all the various areas that are important to feeling our best. And we are spending our time this evening in the medical healthcare arena. However, that is not to discount these other areas that you can see going around this circle. And with the work that we do at Holtorf Medical Group, we are luckily able to really go deeply with people into nutritional science and the use of natural supplements to help people feel their best, as well as help them with hormone balance. This is my first book. It's been out a couple of years now, and you can't see it sideways, but it really is not a large book. It is not a big, heavy textbook. It's an easy read. It is truly meant to be an easy guide to menopause. And in fact, it actually addresses perimenopause as well as menopause. And it's available through the Holtorf Medical Group website, holtorfmed.com, as well as a variety of other places. But it's available through our site. And I talk about the material that we're going to cover this evening. I talk about briefly in the book. A few pages are devoted to this topic, but I'm always happy to have the opportunity to really spend a lot of time, even when I meet with patients, even when we have a whole 1-hour appointment, we have a lot to cover. And so, again, I'm always happy to have the opportunity to spend an extended period of time just talking about the safety of bioidentical hormone therapy and helping women in particular feel more at ease with using these options in order to feel their best. Now, menopause brings a lot of symptoms with it, and without getting into too much detail, briefly, the average age of menopause in the United States, we've been saying, is age 51 years old. However, I am seeing in my practice women younger and younger having menopause-related symptoms, so somehow the perimenopause is getting started younger and younger, probably due to the stress, environmental things, factors, a lot of different aspects to why we're seeing these changes. But in any case, average age of menopause at age 51, and these are some of the typical things that come along with the hormone changes of menopause. So this is depicting hot flashes, the red hot chili peppers here, and temperature regulation goes out of kilter. This can range from just feeling warm during the night to full-blown hot flashes, dripping sweat, that kind of thing. This is the brain fog, the cognitive changes that can come along with menopause. And this is Menopause, and she's at the doctor's office, but she can't remember if she's going in or coming out. And this is a graphic image referring to the dryness of tissues. It's often vaginal dryness, also dry eyes. Other types of dryness in the tissues can be experienced with the hormonal changes. And emotionally can be similar to a roller coaster. And a lot of those changes include sleep disruption, and these are things that have an onset well before a woman actually stops having her menstrual period. So tonight we're focusing not on all of the various hormonal systems that are in a woman's body, but in particular on the ovarian steroid hormones, estrogen and progesterone. And I'm going to give everybody some tools to use to dispel the myths, to do what I call headline busting, because as we will see in a moment, it's always the bad news that gets the headlines. The good news is always the last 30 seconds of the news, whereas most of the news show is taken up with all the bad news. And so when we learn about health information and study findings that are being put out there and covered by the media, I want to equip everybody on this call with some tools to be a very savvy healthcare consumer and really be able to stop and take a moment and be able to look at the information being given and ask some very important questions in order to not be frightened. So the first tool is the difference between relative risk and absolute risk. And one of the major studies that is called the Women's Health Initiative, and that study first began publishing findings in 2002. And as I say, it's unfortunate that it's still producing research papers. They're still analyzing that data, still writing reports from it, and as they do that, media coverage can information and scare us with talking about all the terrible risks of hormone therapy when, in fact, what we'll learn about this evening, that's actually not the case. So we're going to take some time and look at the Women's Health Initiative study. And this study was conducted by a pharmaceutical company and was intended to show a cardiovascular benefit. That is why they undertook the study. The makers of Premarin and Provera put on this study in conjunction with the National Health, and that's what they were hoping to show based on some findings suggested in the medical literature prior to that. So we're going to look at some of the information that was put out there. However, we're going to look at it a little bit differently than you've probably seen it before. So what we're going to learn with the next slide is the difference between the relative risk and an absolute risk of an adverse event with a medication. So absolute risk refers to the numbers of cases or numbers of people that had a particular bad outcome versus a relative risk, which is a comparison between the two. So here is the first, actually let me tell you a little bit more before I change the slide. So the Women's Health Initiative study had many thousands of women in the study, and they were divided initially into two arms of the study. One arm had women in it who had had hysterectomies, therefore they were only on the estrogen, which was Premarin. The women who had their uterus were put on estrogen and progestin, that's the Provera. Okay, so we will see, first we're going to look at the estrogen-only arm. Okay, we'll take a look at that in just a moment. So what happened was that in 2002, the combination arm of the study, the estrogen plus the progestin, that arm of the study was stopped prior to the scheduled time because they found a statistical increase in the risk of breast cancer. And this made it out into the public in shockwaves. And women were really ripped or yanked off of their hormone therapy cold turkey. And I'm just going to tell a very quick story before we go to the next slide where I'm going to talk more about this question of relative risk versus absolute risk. I was actually in 2002, I was in the process of selling the house that I lived in. And one day my realtor showed up and she plopped herself down on the couch and she was beet red and sweating and just felt terrible. And she started to tell me that she couldn't barely concentrate and focus on her job and her life because of the findings that had just come out from the Women's Health Initiative study, and her doctor had yanked her off of her hormone therapy cold turkey, and she was really feeling terrible. So I wasn't too far into my career at that point, and I was younger in my career, let's just say, and but I already knew that over time we were probably going to be able to sift through the data. Again, the media covered the findings as they were published well before we doctors had a chance to go through the information and really be able to see what was going on. So I knew even at the time that it was premature to just pull everybody off of their hormone therapy. And sure enough, over time, we were able to make more sense of the data, and I'll have a whole lot more to say as we go through the next few slides. So what we're looking at here, and if you're in front of your computer and you can enlarge this so that you can see it even more up close, that will be just fine. But in any case, what we're seeing is a little graphic that shows 1,000 women, 1,000 little tiny little figures of a woman. And what you'll see is that In the women who were taking the estrogen plus the progestin, there were 4.1 cases. So basically, if you multiply a little bit, so out of 10,000 women, there were 41 cases of invasive breast cancer in the women taking the Premarin and the Provera. And the women taking the placebo, okay, now they didn't know who they were, there were 3.3 cases. So out of 10,000, that would be 33. So basically, the relative risk was highly significant, the increase in the relative risk. It was just over a 25% increase in risk. Okay? However, in absolute numbers, it was 8 more cases of breast cancer out of 10,000 women. Okay? So that's the first thing. When I tell people this information, they're usually really surprised. This just didn't get covered by the media. What got covered by the media was the relative risk and not the absolute risk. Now, I mentioned something about this just a moment ago. Our next tool that we're going to look at is just comparing statistical significance versus clinical significance. So the study was stopped because, or this arm rather of the study was stopped because it was a statistically significant finding. The study was so large that that small difference in absolute risk translated into a statistically significant finding, and therefore the study was stopped. The question, however, is what's the clinical significance? And as I often discuss with people, and with women in particular, life is about quality of life. And it's really up to the individual to assess what the risks versus the benefits are for her as an individual. Okay? But what we're going to look at now is even more information from the Women's Health Initiative study, and we're going to look at the other arm of the study, which was estrogen alone, because as I mentioned, the estrogen, the Premarin and Provera arm of the study was stopped. However, the Premarin alone arm, the women who'd had hysterectomies, that arm continued. And we will have some interesting findings that we will talk about now. So first we're going to look on when I go to the next page, I want you to focus on the breast cancer line, which is the second line of the chart that I'm going to show you. And then we'll talk about the other figures that are on that page. So what you see on that second line, again, this is the estrogen, this is the Premarin only arm of the WHI study. And what we have is a decrease. You heard me correctly. It's a decrease in the incidence of breast cancer in these women. Okay, so this is interesting. Why didn't it make headlines? Well, first of all, we didn't have this information immediately. The first thing we had was the adverse outcomes. We had the increased risk of breast cancer. This arm continued. So these findings were available a little while after those initial findings. But it was, I was aware, because I was following this very closely, that the incidence of breast cancer was lower in the estrogen users. And it really did not make it into the media coverage. I have barely in the last year or so started to see this covered just in the medical literature. I've never seen anybody get excited in the regular mainstream media about less breast cancer with estrogen. That goes against the common myth about estrogen replacement therapy. Now on this page is some other important information, and what we see, let me touch on a couple of additional benefits. So if you look down a little bit further, you'll see hip fracture and spinal vertebral fracture, and you'll see that both of these were actually a lower incidence. Now, the ironic part is that many studies prior to this had shown a benefit of estrogen therapy for osteoporosis, for thinning of bones. We were seeing better bone density in women on estrogen. But this was the first study to actually show fewer fractures. So it's a little bit ironic that the study that had many thousands of women go off of estrogen finally confirmed that estrogen helps prevent fractures and hip fractures in particular. If you ask people who focus on osteoporosis, they will be very passionate about saying that a hip fracture is one of the most devastating things that can happen to a person. That even various cancers can be corrected with surgery and other treatments, but a hip fracture can truly, truly be devastating. The mortality after a hip fracture is very, very high. So again, we're looking at risks versus benefits, even with talking about this particular form of estrogen therapy, which was Premarin. So if we look at these other incidents, these other events, we see increases. We see increase in the risk of stroke, increase in the risk of venous thromboembolism or blood clots in the legs or extremities. And that is important. Now, I am going to give you another piece of information which is very, very important, and I will refer to it towards the end of our discussion. However, what I want to tell you in summary is that what we have learned in the past 10 years, after many, many publications, they've just come one after another on estrogen therapy, confirming that the increase in these coagulation-related events, like a stroke and a blood clot in an extremity, is due to the fact that this estrogen, Premarin, is given orally. It's given by mouth. And we are going to talk about that a little bit more in just a few minutes. This is what I'm referring to in tool number 3 that I want to give you this evening. So we talked already about the fact that Premarin is an estrogen that was given orally as opposed to other forms of estrogen which are given through the skin. And we're going to distinguish between bioidentical and synthetic hormones in just a moment. However, there's one more piece of the data on the WHI that I want to cover with you this evening before we go on to a few other topics. So this is information that unfortunately you will very often not read in a newspaper article. It will not give the details of the study. In fact, even in my medical email listservs that I'm on, very often I'll have to click through to a link, sometimes a couple of times, to get to the original study. What I will receive is simply a summary. So what's very important is to know precisely the hormone being tested, what outcome was being measured, right? We saw all those different things being studied in the WHI, and so this is also going to be important. And there's so much to talk about with the WHI, and maybe we'll get to more information when we take questions. Also, the question is who is being studied, what age groups. So another very, very important aspect of the WHI is as follows. This was a randomized, double-blind controlled trial, and this is considered the gold standard of medical research at this point in time. However, you cannot be randomized into a group to be given a sugar pill if you're having symptoms when it comes to hormone therapy. So if you have any menopausal symptoms, hot flashes, night sweats, you were not eligible to participate in the WHI. The women who were studied were mostly, on average, in their 60s, well past menopause, more than 5 years after their last menstrual period, not having any more symptoms. So these weren't necessarily women who needed estrogen therapy. And this is a very important point to keep in mind One of the ways that I've heard the WHI summarized is that it was the wrong hormones given. We'll talk about that in a little bit more detail. The wrong women, these were not symptomatic women. They were not women who had recently gone through menopause. And the wrong route of administration, where the estrogen was being given orally. And we'll say a little bit more about that shortly. Now this is one more slide regarding the WHI study that I want to take you through in a little bit more detail. And this is very, very important. So this is the estrogen plus progestin, the Premarin and Provera arm of the study. This is the arm that was stopped. So we see the increase in breast cancer risk. We see an increase in heart attacks. Let me turn back one moment and show you something. This is the estrogen-only arm of the study, and there was, on the first line where it says heart attack, they actually found 3 fewer women out of 10,000 experiencing a heart attack. That was out of 1,000. So, yes, so 3 out of 10,000. However, in the progestin, the Provera and Premarin arm, there was a statistically significant increase in heart attacks. There was the increase in breast cancer. Basically, there were increases mostly down the line, again, with the exception of the fracture data, and also colon cancer, curiously, was found to be improved with this combination. But in any case, we see an even bigger difference in the venous thromboembolism and stroke incidence. So in the combination, the Provera was much worse, really made the whole situation much worse. Now, I want to say one more thing about the estrogen being given orally. So when we take estrogen orally, it has what we call a first-pass effect through the liver. And this stimulates the clotting factors, which are manufactured by the liver, and this is the reason that the coagulation-related adverse events are increased with oral estrogen. So again, we have seen from many, many studies now that transdermal estrogen through the skin in various forms, creams, gels, patches, does not have the increased risk of stroke, heart attack, and venous thromboembolism, the blood clots. So I've used the word bioidentical a couple of times already, so let's just say a little bit more about that. So a lot of regular doctors who aren't familiar with the many variations on the theme of hormone replacement therapy, that they lump it all under what was found in the WHI, bristle at the term bioidentical because they feel that it's just something used to market alternative ways of approaching these therapies. However, there is in fact an actual definition. And so what I mean when I'm using this term, and I think when we use this term here with the Holtorf doctors, is simply that the molecule is identical to what was formerly produced in a woman's body in optimal quantities. All right? So we want to replace hormones in similar form as her body was producing previously. So this can often be, there are several forms of estrogen, and without getting into too much detail, it has to do with the biochemical composition and the structure of the hormone molecule of estrogen, but it comes in various forms, and usually a compounding pharmacy, for example, when we work with, we have a compounding pharmacy that we work very closely with to formulate a combination of 2 of these forms, and then a woman's own metabolism takes care of the conversion to the third of those forms. Now, two of them in particular are estradiol and estriol. Those are the ones we normally put into bioidentical hormone therapy. Estradiol is the potent form that gives women the benefits in terms of how she feels, skin quality, blood flow, especially to vaginal tissues, temperature regulation, mental function, all those kinds of things are primarily from estradiol. This is the dominant form through most of a woman's life from puberty until menopause. However, during pregnancy, the dominant form is estriol, and there are now an increasing number of studies. Some of them are animal studies. There's actually some studies in women as well that show that estriol actually has a protective effect on breast tissue. And so what we're looking at is using hormone therapy in a way that replenishes what a woman's body is no longer making in optimal amounts. This is as distinct from synthetic or non-bioidentical. So for example, in the WHI study, they used Premarin, which comes from horses. It actually is a shortening of pregnant mare's urine. That's where the name Premarin comes from. And this is almost as non-bioidentical as it's possible to make. There are several pharmaceutical products that can be considered bioidentical. For example, there are estradiol patches that are technically bioidentical, but they don't include the estriol, which has the protective effect on the breast tissue. One of the theories of why there's less incidence of breast cancer in women who've had term pregnancies is because of the high levels of estriol during the pregnancy. So if we have more questions regarding that, we can take questions about that. All of the things that I'm touching on quickly can be discussed for extended periods of time. So if people have particular questions, we will definitely say more about that. All righty. So we talked a little bit about this route of administration. Does how you take the estrogen make a difference? And the answer is yes. Transdermal is preferable. So even if it's made by a pharmaceutical company, if it's just estradiol, if it's through the skin, that is still preferable to an oral form of estrogen. Okay. Now I wanted to go ahead and touch on the very challenging topic of hormone therapy after breast cancer. Now, a couple of things are very, very important to remember. The Women's Health Initiative, the WHI, as we said, it actually showed less breast cancer in women taking Premarin. And this is very unfortunate that it hasn't made it out into the common understanding of hormones and hormone therapy, that even that study showed this finding. So in any case, another thing that I always say to patients is that, and this is actually an understanding shared by a lot of doctors at this point, that estrogen itself does not cause a breast tissue cell to become cancerous. If that mutation occurs, estrogen can potentially feed that cell and cause it to overgrow and lead then later to a breast cancer. However, as I often say to patients, if estradiol caused breast cancer, we would have most women developing breast cancer. That's number one. Number two is that where we see the highest incidence and the increasing incidence of breast cancer is after menopause. So this is confirmed by quite a few studies. I listed just a few of them here, but I'll just tell you about them briefly. And we have information in our offices regarding this and all of the summaries of all of these studies. However, quite a few studies exist that actually looked at breast cancer survivors and compared, they either divided them into groups or they did observational studies, but literally many, many studies. I'm looking at a summary of 9 of those studies as we speak. And some of them were smaller. The smallest one that I'm looking at had about 56 women who were using hormone therapy, a total of about 300 women in the study, up to a study that had over 2,700 women. This study was published in the Journal of the National Cancer Institute in 2001. And a lot of these studies were done in the U.S. One was done in Finland, another in South Africa, another in Australia. So it's really studies from all over. Every single study confirming these were in women who had had breast cancer and were given hormone therapy. Many of them were very young, and they were truly, truly suffering with menopausal symptoms. Therefore, they were, of course, consent was obtained, and they were given hormone therapy. And in every single study, hormone therapy either didn't make anything worse, or in many of them, the risk of death, the mortality, was lower in the women using hormones. And this was all in women who had had breast cancer. So I've had many patients who have hesitated to even use vaginal estrogen after breast cancer, and vaginal estrogen doesn't even have a systemic effect. The studies I'm talking about here were women actually given oral estrogen and various forms of progesterone or progestin, and still did not have a worse outcome. They either had similar risks or the hormone users actually did better. And by the way, this was actually confirmed in the WHI. So of those charts that we looked at, the women who were using the Premarin and Provera actually had a lower risk of mortality from all causes. So the risk of death was lower in the women using the hormones than in the women using placebo. This is another non-headline, another piece of important information that really never made it out to the public. So, unfortunately, there are some sad facts about the current state of medical information. To a great degree, at least in the United States, medical research is largely funded by pharmaceutical companies. So this is a for better or worse situation for us at the moment. And it's sort of a little, becomes a chicken and egg situation where they're conducting the studies and they have to end up with something that they can patent and then sell as a medication. Whereas a bioidentical hormone occurs in nature, therefore it cannot be patented. So we're going to continue to see attempts to develop different medications, which won't necessarily be American research on bioidentical hormone therapy. Another aspect of this is the fact that negative findings are really underreported. And this goes along with how the media is inclined to really only report on a more sensational or scary aspect of things. I want to say one more word back on the topic of bioidentical versus synthetic. We've been talking throughout the evening about we have referred, and I spoke a little bit about the Premarin being the estrogen. I want to say a word about the Provera. So it's very, very important to distinguish between progesterone and a progestin. Provera is a progestin, and it has now been shown in many, many large studies. In 2007, there was a very, very large European study that confirmed yet again that a bioidentical progesterone hormone as part of a hormone therapy regimen causes no increase in breast cancer risk, whereas Provera has now been confirmed in several large studies that have come out since the WHI first came out to show that Provera does, in fact, increase the risk of breast cancer. Another finding is that Provera, or medroxyprogesterone acetate, increases cardiovascular risks. And we saw that with those charts with the WHI data. So there are multiple studies published in very important peer-reviewed journals, both in cardiology, in various specialties, showing that this molecule, the medroxyprogesterone acetate, or commonly marketed as Provera, increases risk related to coagulation issues, so heart attack, stroke, and peripheral clots. Okay, so these are all very, very important things to keep in mind, and showing the proven, it is now really proven beyond a doubt that the bioidentical forms of the hormone therapies are safer than what we've been mostly exposed to in the synthetic varieties. I will also say just very briefly that natural progesterone or bioidentical progesterone has a sedating effect on the brain that the synthetic forms do not. Prometrium is a bioidentical pharmaceutically made progesterone product. However, because of the alteration of the molecule so that it can withstand being broken down immediately in the stomach, causes this molecule not to have all of the effects of a completely bioidentical progesterone made by a compounding pharmacy. So a natural progesterone has a sedating effect on the brain and can be very helpful with sleep. And sleep disturbance is a very important problem for women in perimenopause and menopause. And a bioidentical or natural progesterone can be extremely helpful without increasing the cardiovascular risks. So it's not all bad news. There's good news as well. The internet is opening up the world of information and reporting. It can be a little overwhelming. We've gone from the information age to the too much information age in a lot of cases. However, we are able to really see these other articles and studies performed in other parts of the world and not be so insulated with just U.S. data and what the FDA is looking at. They normally focus only on studies performed in the United States, whereas we now have access to worldwide information. So as I've mentioned throughout our conversation this evening, there are many studies supporting what we talked about today. I didn't want to get too technical with doing references. However, there are lots and lots of these studies are available on the holtorfmed.com website, and I encourage everyone to look there, and you'll see dozens, adding them all up, hundreds of references in the articles that are posted there. And the other piece of good news is that in medicine, especially in women's health care, I think in particular the tail wags the dog, and women want to feel good. We want to feel our best as long as possible. 100 years ago, age 50 was just about close to the end of the line for those women who survived childhood, and now it's the middle. And we want to spend the second half of our lives feeling our very, very best. We want more options. We want them to be safe options, and luckily, more and more doctors are learning about these alternatives, and this is definitely an area of expertise with the doctors from the Holtorf Medical Group, so we are happy to do various ways of doing consultations with people, as well as we look forward to getting to meet new patients every day and taking care of the patients that we have. And I'm just going to wrap us up with some images of balance, which is what we want in our lives. We want to really, really feel our best. So I really appreciate everyone. I feel like we've been going for 45 minutes, and I still feel like I've only scratched the surface. So but I would like to go ahead and take questions at this point. and then we will go from there. And we'll continue recording so that people who are watching the call or listening to it afterwards can have the benefit from the live call.
And Dr.
So Jenny,
Lyster, Dr. Holtorf is here, and he wanted to address some of the comments that we've been seeing.
Well, Dr. Liz, a great presentation. Thanks so much. Some great information. There were a couple questions and comments. I don't think you can see it. I just wanted to just make a couple comments about them and some questions that came up on the written comments, and then we can have you take questions. But one was about the statement that transdermal estrogen builds up in the tissue, so it can't be regulated or dosed appropriately, then it builds up in the liver. And that's exactly the opposite of what studies show. And it actually is good, and the estrogen does build up in subcutaneous tissue, which makes it time-released. So you get a nice constant level, so you don't have to be taking it 4 or 5 times a day. It does build up in the subcutaneous tissue and then slowly releases, which is perfect. And the good thing is, when you take something orally, it goes to liver, again, what's called first-pass metabolism, and that's where it all gets broken down in a lot of metabolites. But when you give it transdermally, it bypasses that. So it definitely does not build up in the liver, and all the studies show that no increased cancer risk. And I, again, in my bioidentical hormone debate, reviewed all the studies on bioidentical hormones versus synthetics, not only show that, yes, it's true, they're very different in risk for breast cancer. They reduce the risk of breast cancer, reduce the risk for heart disease, while synthetics can certainly increase it. They also, when you do it transdermally, you don't have any increased risk for stroke and heart attack like you do when it was taken orally. And especially that's true if it's with synthetic. It doesn't matter how you take it, orally, transdermally, you're going to have increased risk of stroke, heart attack, and breast cancer. But really the way to take estrogen is transdermally. Then it talks about things about saliva testing, what's better, serum or saliva. And you got to remember that all tests have their limitations. So you really, you can't hang your head on any one test. So you got to know the limitations of each test. But when you say, what's the difference between saliva and serum? Well, one thing when you look at transdermal, let's say you give transdermal progesterone. The saliva tests go very high. Serum doesn't go up, right? So it's very low. Well, who's correct? That's the whole question. So there's one study, a couple studies, they give people transdermal progesterone. They check their saliva and then check their serum. Serum was low, saliva was high. Then they did endometrial biopsies, and they found there was no progesterone effect, showing that the saliva artificially was elevated with the transdermal. So I always worry about people doing low-dose progesterone creams based on saliva, that there could be risks for endometrial hyperplasia and endometrial cancer. And also I did pretty much everyone that came through, I did saliva, 24-hour urine, and blood on pretty much everyone I could. And I found that the 24-hour urine and blood correlated pretty well, and saliva was all over the board. And also we have so many people come in, and they're on estrogen, they're got all these hot flashes, but my doctor says my estrogen's high. Well, it just doesn't fit with the clinical symptoms. So, again, all tests can be useful. They're a piece of information, but you got to really watch out with saliva testing. They can really lead you astray.
That's right. And also we always say this, that we're treating the patient and not the numbers. That's great.
Okay, Dr. Lyster, we'll go ahead and start with we had some really great questions for you.
Great. Thank you, Dr. Holtorf. That
Anna
was
would like to know if you recommend cycling with bioidentical transdermal progesterone 15 days per month in a postmenopausal woman versus daily use.
That's a great question. So I'm going to, again, Dr. Holtorf just touched on the issue of transdermal versus oral as far as progesterone, and that there's a little more to that discussion. So what I'd like to address is the continuous versus the cyclic. That's the medical terminology is continuous therapy where we give estrogen and progesterone every day versus cycling, which is what this person is asking the question. So personally, my own view of the matter is that I do not generally want to cause bleeding in a woman who is in menopause, and therefore I favor continuous therapy rather than doing the cycling. There are some people out there who feel very strongly that it should be cycled. I don't object to that as long as they're not having bleeding. When a postmenopausal woman has bleeding, everybody gets into a little bit of a dither, and she starts undergoing a lot of tests that she probably doesn't need, some of which can be painful, like endometrial biopsy. So generally speaking, the other question is, do the receptors get saturated by giving the progesterone every day? And that's easy to tell clinically. If a woman if she has a benefit, she feels better and she stays feeling better, then her receptors are doing just fine. If the effect wears off to some degree, then that's a possibility. And so sometimes cycling can be helpful with that. Generally speaking, I personally favor continuous therapy. Whatever makes it easier for my patient to feel good and be compliant and stick with her regimen.
Thank you, Dr. Lyster. Our next question is from Rosemary, and she says, I've read a lot about that women do not need to take any estrogen and just take progesterone. What do you think of that?
Okay, great. Well, I really appreciate that question because one thing that we didn't talk a lot about this evening is, should women take hormones at all? And so first let me just answer the question as Rosemary asked it. So there are some who assert that only progesterone will give the benefits. Most commonly in my clinical experience, women need some estrogen to feel their best. Estrogen helps with mood, mental function, temperature symptoms. Some women can get some relief from progesterone. For example, there are over-the-counter natural bioidentical progesterone creams, and I do not think that there's any harm in pretty much any woman trying that if she's having any types of hormonal symptoms. I'm sure there's people out there who assert, okay, do progesterone and not estrogen. Personally, I favor doing a little bit of each in most women. The other thing I wanted to say is that, there's a continuum of doctors. There's one end of the spectrum where there are traditional types of doctors, which is most medical doctors who were really spooked by the WHI findings and don't think women should be on any hormones, to the other extreme of the full anti-aging. Suzanne Summers is delightful, and she self-admits that she's on that extreme. She uses high doses of estrogen and progesterone even though she's had breast cancer. So she's also kind of the opposite extreme, and we're definitely not down at that extreme end of the spectrum, and I definitely am not. However, I will say that the benefits of estrogen, I think, warrant being on at least a little bit of estrogen forever, even in the face of breast cancer. In order to have comfortable sexuality and comfortable sleep and a comfortable daily life without having temperature issues. However, also the bone density question also warrants at least a little bit of estrogen, probably for most women for most of their lives. That's my take on that.
Thanks, Dr. Lyster. We have a great question from Sarah. She stopped having periods almost 7 years ago and has not been on any HRT, but she does have osteoporosis and hypothyroid. Is it too late for her to start hormone therapy?
Fantastic question. So this was an important issue that was analyzed at length after the WHI came out, because clearly the women in that study had been, like Sarah, a few years without any hormone therapy, a few years into menopause without any HRT. So the question is there a quote-unquote window of opportunity in which you should start hormone therapy? And probably the answer is yes. What happens is that when there's a period of time without hormones floating around a woman's system, that's when we start to see inflammatory changes begin, and starting hormone therapy can potentially have more risks if it's started further into menopause, say, for example, more than 5 years after the onset of menopause. Having said that, what I would discuss with Sarah is risk versus benefit. If she's having any types of symptoms where we feel, and she is because we've got the thinning bones happening, I still believe from my analysis of many, many studies is that the benefits would outweigh the risk. Estrogen remains the best treatment for bones. Even taking calcium, the body cannot absorb calcium very efficiently when it is not in the presence of estrogen. So perhaps a very small dose. There are pharmaceutical as well as compounded bioidentical ways of doing a very tiny amount of estrogen through the skin, as we said, to benefit the bones. I would say that the probability that it would be of benefit is higher than the possible risks. Great question.
There's my real quick comment on that, and I totally agree with what you just said. And if you look at the WHI, when they took the oral estrogen and progestin, it really most people die within the first year or two because the oral estrogen increases clotting factor, so they had stroke and a heart attack with people who had heart disease. So for one thing, you don't want to do oral estrogen. If you do transdermal, their studies show no increased risk in stroke and a heart attack because you don't get those increased coagulation factors and increased inflammation. So that risk is negligent, is eliminated. Then also, though, estrogen is better for prevention than it is for reversing, let's say, heart disease. So that's why the sooner the better, but you're going to still prevent heart disease going forward, as well as osteoporosis and those things. So I totally agree with what Dr. Lyster said as well.
Thank you. And we got a question from Jackie. She's 34 years old and gave birth to twins 3 years ago. Since then, she's gained a lot of weight, has had no libido, brain fog. She sleeps well but is not refreshing, and she has a low-grade fever the week before her period. So her question is HRT something I should be looking at, or is it for only women in menopause?
Excellent question. That's another wonderful question. So I would say yes, definitely bioidentical hormone replacement therapy is not only for women in menopause. In fact, we have used it in many, many patients to actually enhance fertility and really get things back into a good balance. And whether it's before menopause or after menopause, bioidentical estrogen and progesterone have been shown to be helpful with weight management. And I definitely think it could be a very important part of a whole overall balanced program of doing hormone balancing. So definitely not only for women in menopause. Can actually definitely be for younger women. And when I have women who are not yet in menopause, and I'm using a little low dose of estrogen and progesterone, I often will make sure that they're taking other measures to not add to the number of kids that they have, because very often fertility will be enhanced. As a woman gets into balance, weight comes down, she feels better, fertility is better, and pregnancy can often happen. So it's a great question.
Okay, and I have another great question for you. Bonnie has heard that testosterone injections for females helps with memory loss and clears up foggy thought processes. Have you heard of this type of hormone being used on older women?
Absolutely, absolutely. So as I said at the beginning of our talk, we really were focusing on estrogen and progesterone. Testosterone is absolutely worth a shout out. Testosterone for women helps with mental function, feeling of well-being, sex drive, muscle building, to have enough muscle mass, which can then in turn help with weight management. So I always discuss testosterone, whether it's injection or through the skin or under the tongue. Again, we're always going not swallowing testosterone. We don't do testosterone therapy orally for women. However, in any of those other forms, it can definitely round out a bioidentical hormone therapy regimen. Mm-hmm. Absolutely.
And we'll go ahead and take a couple of quick questions before we end the call. We've had so many great questions, Dr. Lyster. I have a question from, it doesn't say from. Sorry, I lost the question. Is it better to take estrogel? Bioidentical won't work as I am hypopituitary due to surgery and compounded progesterone, or nothing at all?
Well, okay, I'm not sure what the options are. Okay, if someone who is hypopituitary definitely needs to see someone who's really has expertise in the area of hormone balancing. So go ahead and give me the question one more time, what the options are as far as she's considering.
Is it better to take estrogel and compounded progesterone, or nothing at all? She's stating that Bioidentical won't work.
It is Bioidentical.
Well, I guess that's the part that threw me off as far as Bioidentical not working, because definitely works for most people. So I would say, based on the literature that we've reviewed, as well as dozens of other studies that we didn't have time for tonight, that the benefits outweigh the risks. In my opinion, the benefits far outweigh the risks, and especially in someone hypopituitary where other things are also deficient. I would definitely think that at least a little bit of estrogen, a little progesterone. Again, we assess people one by one based on how they're feeling and what their priorities are. But generally speaking, I feel that a good regimen of hormone therapy with the safer options is in fact preferable to not having any hormones circulating.
But I'll do a quick comment. We treat a lot of hypopit patients, and they often get poorly treated and underdosed. So yeah, there's no reason to think that bioidentical hormones wouldn't work. And estrogel is bioidentical estrogen with progesterone, testosterone. You're going to have the whole range of hormones off. What really gets underdosed is thyroid and adrenals, because they're tested as normal, because the TSH looks normal although you're low thyroid. Because again, the pituitary is not working, the hypothalamus pituitary thyroid axis isn't working, the same with the adrenals. So you need to really watch for that, and also growth hormone. They'll basically not treat the growth hormone deficiency when you become an adult. So those are a couple things to look for in addition to making sure your estrogen and progesterone are optimal.
Thank you, Dr. Holtorf. And we'll take one more question before we wrap it up for the evening. We still have a lot of participants on. And this is from Debbie. She has Hashimoto's, but has had a total thyroidectomy. She's 47 years old and has been getting bad night sweats since switching her Thyrospent to night. My periods are getting farther apart. Should I have any hormones tested? She does get a regular TSH, free T3, free T4. Do I need to get anything else checked? I still have a lot of autoimmune issues, pain, fatigue, and brain fog.
Okay. All right, great. She sounds like a great candidate for our 30-minute phone consult program, right, Jenny?
Yes, she
to
sure
really
does.
review everything in a lot of detail. But in any case, I would say that absolutely. So I didn't get into the definitions really. We said menopause is average age of 51. That's when the periods stop completely for a whole year. However, perimenopause can be many, many years. The textbooks say 2 up to 8 years, but I've had patients where perimenopause has gone on for 10 or more years. So that's what it sounds like to me from the brief description. So definitely worth checking a variety of hormones as well as other related tests. And, of course, the testing that we do is very, very thorough and includes standard things that most doctors will check, as well as a lot of non-standard tests that will reveal best ways to treat people and have them really feel their best.
And just a quick comment on that. I mean, there's a lot of issues going on there with autoimmune disease. First thing, think low-dose naltrexone can be very useful. Pain, fatigue, brain fog, likely, chronic fatigue syndrome going on. You need to check for chronic infections, Lyme, a lot of other things. The fact that if she's had a thyroidectomy and just taking T4, which is a new T4 medication, there's nothing special about it, but it's just straight T4. The studies show if you've had a thyroidectomy, it is impossible to get normal thyroid levels in the tissue by just giving T4. And if you go to our nonprofit site, National Academy of Hypothyroidism, nahypothyroidism.org, you see a lot of studies there. So they can keep pushing your thyroid level up. They'll say, oh, you're getting enough thyroid, but you're still achy, you're gaining weight, brain fog. and because your tissues are just starving for thyroid. So you really need to find someone who can very comfortable giving T3 because, again, study after study has shown that, especially with the thyroidectomy, you need T3. And when we do a lot of actually straight T3 instead of T4, and especially it looks like you have fibromyalgia chronic fatigue syndrome, the studies on that are showing dramatic improvement by just giving the T3. So a number of different therapies it looks like would be potentially useful for you.
Thank you, Dr. Holtorf. Well, Dr. Lyster, thank you very much. We'll wrap it up with the questions if you had any closing comments.
Well, I just appreciate Dr. Holtorf being on the call with us. That's really fantastic and excellent questions. Thank you to everybody that was on the call. And we are easy to reach in lots of different ways. And so hopefully you'll share the information with friends and family and loved ones, and they can watch the video of the presentation, including all of our comments and answers to the questions, on holtorfmed.com.
Thank you very much, Dr. Liz. We appreciate it, and we will have this webinar posted on the website with all of the questions and some of the questions that we didn't get answered, and those will go out in an email as well. Thank you very much for joining us, and watch the website for the next upcoming webinar. Thank you very much.